Good afternoon to all. Today I'll be discussing about another topic from recent advances in hematology, and that is Fanconi's anemia. And without talking much, I'll just come to the topic. So Fanconi's anemia, it is a rare autosomal recessive disorder that is characterized by pancytopenia, and then there is hyperpigmentation in the skin, and there can be developmental delay as well. These patients have increased susceptibility to leukemia, especially acute myeloid leukemia, myelogenous leukemia, and then myelodysplastic syndrome and other malignancies. The hallmark of this condition is the chromosomal breaks and interchanges that occur in the cells. And the chromosomal breaks are increased due to mitomycin C, deoxybutane, and cisplatin. The incidence in the world is 1 in 1 lakh live births, and that also it is more common in white Africans who are present in the South Africa. White Africans means maybe a hybrid variant, like the people who had married Americans and then they are white Africans. So the clinical features are, as you can see, the baby in the side, that is they usually have short stature, which is a very common clinical feature. Then you can see the hand, they might be having absent thumb or very small rudimentary hypoplastic thumb. There won't be radius, absent radius, and then microcephaly short for the age, small head for the age. Then there can be renal anomalies, cephalic spots, and then skin hyperpigmentation, as you can see. And then in male child, there can be abnormal genitalia as well. So they are usually their autosomal recessive condition mainly. So that is mother will obviously a mother or father can be a carrier for the disease, and then when both the genes, that is recessive genes, come together, they can be get affected. Okay, so the child has a 25 percentage chance that he or she can be affected because it is autosomal, so both male or female can be. And then they usually present in the age of either 8 years or 40 years of age also they can present. So it is depending upon the gene penetration or the manifestation. Okay, there are so many mutations in Fanconi protein, and in which there can be the defective gene can be functional or how much non-functional or how much functional because of the penetration. Because of that, the age of presentation can be even 40 years. Okay, and then high risk of myelodysplastic syndrome, acute myeloid leukemia, and solid tumors are obviously present for these people. And people who are having BRCA2 mutation, that is Fanconi, there is A, B, C, D, E, F, G, etc. So in the 13 mutations, if it is Fanconi D2, so that gene was later discovered, it is BRCA2 gene. So if you have that mutation in those people, leukemia will present at even 2 years of age, and median age of 2.2, and brain tumor also can occur by the age of 3.5 years. That is a median age. It's not like exactly 3.5, it can be 3, 4, 5, etc. So in liver, these people can have hepatocellular carcinoma, hepatocellular adenoma, focal nodular hyperplasia, etc. And these are more commonly attributed because these people have prolonged androgen therapy, which is given to raise the counts of the patient because they have pancytopenia. Because of that, the patient can have HCC and all later on. So pathophysiologically, they are usually autosomal recessive disorder, and there is 13 gene mutations that are seen that can be associated. In them, they are A, B, C, D1, D2, E, F, G, I, J, L, K, M, N. Okay, there was before H and K and all. Then later on, they found that the genes which were responsible for A and H was the same, so they kept only A. So like that, and I said ki D2 was later on found out that it was BRCA2 gene. D1, yeah, D2 was BRCA2 gene. So anyway, these genes can be later on were discovered as different genes like A, etc. But for this discussion, we will keep it as FANC A, FANC B, FANC C, D1, D2, etc. So every other mutations are autosomal recessive, but FANC-B gene is X-linked recessive disorder. Okay. So what happens here is that when DNA damage occurs, okay, so there are DNA breaks that is occurring, especially if you're exposed to UV radiation, etc. There can be DNA breaks, DNA damage, as we all know. That is why we put sunscreen. Okay, so to prevent this DNA damage breaks. Anyway, so when these DNA damage breaks occur, so what happens is that normally in our body, this FANG, G, A, C, E, F, and D2 forms a complex, okay, nuclear complex, and then they will cause and then they will bind with ubiquitin, and then this complex of BRCA A2, RAD5, D2, etc. So this complex helps in DNA damage response mechanism. Okay, so they either repair the strand, or else if it is like to an extent irreparable, then they will cause the cell necrosis or apoptosis, and then they will just degrade the cell. Okay, so this complex formation is very important for the DNA damage repair mechanism. Okay, as well as they are also involved in neutralizing reoxygenation induced oxidative stress. That is reoxygenation because there is free radical mechanism that is occurring. If you remember the cell injury chapter, if you have studied a free radical mechanism and how cell injury is occurring, if you are giving reoxygenation, that is if you are giving if a patient had MI and you are giving you took out the clot, then there is again you are giving the patient blood, okay, through the thrombosed, the previously thrombosed vessel. So there was already injury occurring, so there was free radical injury occurring, and when you are giving more blood supply again which was closed there, then the oxygen that is coming from the fresh blood will increase the free radical mechanism, and then there will be reoxygenation induced cell injury more, or it can be said as reoxygenation induced oxidative stress. So this is occurring due to free radical mechanism and the reactive oxygen species. Okay, so this mechanism also, to curb this mechanism and the DNA damage that is occurring because of that, you need this complex especially. So when cross-linking agents, I said like mitomycin, CD, epoxy, butane, and all etc. are using, they produce reactive oxygen species. Okay, so because of that, there is induced oxidative stress and DNA damage, etc. And already, if there is mutation in the FANC genes or proteins, then the DNA damage is not, or DNA breaks are not repaired. Okay, that is why we get in this condition so many chromosomal breaks and DNA breaks, because either it was occurred due to physiological mechanisms like UV radiation, etc., and these are not repaired, so they stay like that only in our body. So screening test is like we take some of the cells in which there is mutation, or this Fanconi anemia patients mm, cells, and then we put cross-linking agents like mitomycin, CDA, epoxy, butane, and cisplatin. And what happens is that when these cross-linking agents are put, I said there is production of reactive oxygen species, and because of that there is DNA damage, DNA breaks, as you can see. And because if there is Fanconi's anemia, the nuclear protein or gene is affected, DNA damage repair mechanism is affected, and the breaks stay as itself. There can be increased breaks also, so induce more breaks, you will put this mitomycin C, etc., and you will see. So if it is a normal patient's sample which is having normal FANC nuclear complex, then you cannot see these breaks. Okay, so when there is mutation, then you see there is increased breaks. So this test is done by exposing the culture of phytohemagglutinin stimulated peripheral blood lymphocytes or screen fibroblasts. So for the patient's peripheral blood lymphocytes we take, or you either take skin fibroblasts, and they are stimulated with phytohemagglutinin first in the culture, and then into the culture you add cross-linking agents like mitomycin C, etc. And when they produce reactive oxygen species, and then they will produce chromosomal breaks, etc., you will check that it is increased in comparison to the normal control cells. Nextly, we will do bone marrow evaluation to the patient. So you can do either aspiration or biopsy. And aspiration or biopsy, either way, it will be very hypocellular. You know, Fanconi's anemia is an example of aplastic anemia. There is no cell production itself, because hematogenous the precursors are reduced. So Fanconi's anemia, in this condition, there is DNA damage, etc. Due to the mutation, there is also hypocellularity. There is no like very decreased production of RBCs. Okay, because of these mutations and DNA damage and repair. Because you need the cells to get divided. So the extremely dividing cells are affected fast. Okay, so in our body, the places where there is extreme cell division is, one is our GIT system, in which the inside the cells are constantly getting renewed, and skin cells, in which it is constantly renewed, and other thing is bone marrow cells, which are highly dividing, because these are required for our body. Okay, so these cells, there is DNA damage, and the repair mechanism is not affecting, and all because of all these things there is decreased production, and because of that there is hypocellular marrow. Okay, it is replaced by fat cells mostly, and then some stromal cells also you can see, in which there will be lymphocytes, and occasionally if you are seeing any RBC precursors, those RBCs are also dysplastic. Okay, and then you can use confirmatory tests like single parameter flow cytometry also. Like we used this test screening, for screening test we used culture with cross-linking agents. Like that, for confirmatory you can use single parameter flow cytometry test, in which these DNA breaks are seen in S phase usually. So the cell is arrested in S phase, and then you will see flow cytometry and you will see the chromosomal breaks. Okay, and then you should obviously go for genetic counseling also for the patient, to check whether the siblings are having Fanconi's anemia or not, and whether they should have children. So this disease occurs, and that can be hereditary as well. That is what you have to counsel. So management overall, the overt bone marrow disease occurs by the age of 10 years. Okay, so you imagine how young age the patient can be affected if there is so much of gene penetration, or the main gene protein is affected, then the Fanconi's anemia can present fast, and the median survival for such patients are almost 7 years only. Okay, by that age the patient will die also. They will succumb either to the hypocellularity, and there is no bone marrow, no immunity for the patient, and then you will give androgen therapy to improve the blood cell counts. The standard or curative therapy is hematopoietic stem cell therapy for that also, but you will get HLA matched blood relative for, or any donor for giving the hematopoietic stem cells. Then as augmentation you can use chemotherapy and radiation also, because Fanconi's anemia cells are little sensitive. Then but even if you did the hematopoietic stem cell transplantation also, after 5 to 10 years the patient has a risk of myelodysplastic syndrome, acute myeloid leukemia, and solid tumors, etc. Okay, and in Fanc C and Fanc B defect cases, you can use cross-linking chemotherapeutic agents like cisplatin. And in research, now there is gene therapy studies and all undergoing. So we conclude by saying that in India, Verma et al. Had done a study on Fanconi's anemia. So they took 728 patients of aplastic anemia, and in that they have found that there was 57 patients, or 7% of the aplastic anemia cases were Fanconi's anemia, and in those 57, 3 had developed acute myeloid leukemia later. So, Fanconi's anemia should be considered in all young adults and children with hypoplastic or aplastic anemia, unexplained macrocytosis, myelodysplastic syndrome, acute myeloid leukemia, or epithelial malignancies which are presenting in early age with or without the physical anomalies. So, I said there is hypoplastic thumb, eps and radius, short stature, etc. So, it is not very necessary that these physical manifestations should be there for the patient. Okay, there are many cases where there won't be any physical anomalies, but there will be the bone marrow anomalies, etc. also. So that doesn't mean that the patient doesn't have Fanconi's anemia if he is not having short stature, microcephaly, etc. So these are the things that you should keep in mind when a patient comes with pancytopenia and hypoplastic bone marrow. So we end this presentation, and this was a topic that I took from Recent Advances third edition of Hematology, and I extend my gratitude to Tulika Seth, ma'am, who has contributed this article to the Recent Advances. Thank you.